Is Everett on the line yet?
Yes, I'm here. Good morning, Diane.
Good morning. I just making sure everybody was presenting his
I had to download the latest version of GoToMeeting.
Oh, okay.
Yeah.
So, did you want to do your own slides, or did you want me to do the slides for you?
I would love for you to do the slides if you would be happy to do that.
Yeah, no problem.
Okay. Thank you.
Okay, we're going to get started here in just a couple more minutes. We'll start. Okay, so we'll get started. Today we have our Opioid Resource Network from Benton Franklin and Walla Walla presenting for us today. And also they have a couple guest speakers, Nadine and William. So we'll go ahead and get started, and we will start with Nadine, I believe.
Just start right out. Hi, I'm Nadine Pulfer. I'm a physician assistant at Blue Mountain Heart to Heart. We have a medication-assisted treatment program that is part of a study at the University of Washington. And we also are part of the Opioid Resource Network. So basically the same people, but two different programs. The Meds First program is for 6 months, and we'd like to hand them off, but we have limited resources here. So some people we end up keeping and seeing as part of our opioid resource network. My previous occupation was in pain management, so I've seen both sides, a lot of sides to the opioid issue, and I'll bring both of them to play here. There is a lot of stigma around the opioid use. A little bit less, you know, we all live in wine country. There's certainly a little bit less with alcohol, but they are still quite a bit the same problem. We still use a lot of stigmatizing language, like abuse and illegal drugs, as opposed to like alcohol. We don't use that term. Abuse, even the Greek meaning of it to start with is kind of pejorative. And so we're kind of, and people who use opioids are abusers. When I worked in pain management, you know, people tell me they take the pain pills, but they're not like those other people. But of course, I would have to tell them your body doesn't really know the difference between the two. So we try to use terms such as people who use opiates, people who use stimulants, rather than the terms that are stigmatizing, like abusers and addicts. Don't like that word either. So, oh, thank you. So this is probably not anything new to any of you, that opiates act on opiate receptor sites, and they all are very similar as far as where they behave. They behave a bit differently on those opiate receptor sites, and some of them are longer acting, and some of them are very short acting. As we've seen with the onset of fentanyl, fentanyl does not last very long. So the people that we see that use fentanyl will often dose 10 or more times a day. Although the opiate receptors are found mainly in the brain and the gut, it's certainly everywhere in the body. So as evidenced by withdrawal symptoms. The opiates all have the properties that they relieve pain. They depress the breathing, they cause euphoria or high, suppress cough and diarrhea. Of course, a lot of the people who use opiates for long periods of time do not experience a high like they used to. They do, but the stimulation of the production of endorphins is a common trait. They're naturally found or they're man-made. I would say that this says that heroin is man-made. I would say we're looking nowadays the fentanyl and the oxycodones and those kinds of things that are semi-synthetic or more man-made. Next slide. So it's really this simple definition of opioid dependence as a physical state where the body adapts over time to the presence of opioids. They develop a tolerance, they need more to get the same effect, and they experience withdrawals in the absence of opiates. Next slide. So, opioid dependence, and I had this discussion a lot with my patients who took pain medicine, as opposed to heroin. But after the body given exposure to opiates for a long enough period of time, will develop a dependence upon that. It makes changes to the brain. It makes neural pathways that create the seeking of and the supplying of opiates to the body, the normal pathway to stressors, whether it's pain or emotional stress or that sort of thing. Pretty soon there's a pretty strong pathway in the brain that goes there. The good news is that there's the neuroplasticity, which means we can also change that. And for people that we've seen who have done, whether it's heroin or oxycodone for long periods of time, some of those changes can be permanent, but so they need treatment for a long time or forever. We'll get back to that. So biological dependence is simply that, the physical changes that take place in the presence of opiates in your system or the lack thereof. Psychological use is the same kind of thing that drives all the compulsive behaviors, such as gambling or alcohol use or nicotine or sex or any of those kinds of things. It's a compulsive use used to reduce stressors. That becomes their one simple coping mechanism. And oftentimes it affects life in general, especially when they are illegal drugs, because pretty soon your seeking of and your use of and the people that you hang around with precludes any other activities, such as your relationship with your families, being able to hold down a job, being able to go to, perform at school or other kind of social obligations. Next slide. Now, certainly what we typically think of it with opiate dependence is a downward trajectory. And, part of the DSM-5 way to categorize it, one of those questions are, do you keep using it even though you know it's damaging? Have you used it in ways and during times when you know that it could be dangerous to yourself or others? Have you tried to quit and just found it increasingly too difficult to do so? Do you spend a lot of time using or recovering from using? And the dangerous situations, oftentimes we talk to our patients about, like, have you driven while you were high, or have you been responsible for children's while you were high, and those kinds of things. And those are all part of the DSM-5 criteria for opiate dependence. Next slide. So we're really looking at improving the access, increasing the access to treatment. And the first part of that is being able really to understand who in our population is currently using. And best statistics that we have is that 1 in 10 or 1 to 12 Americans at this time are actively using and dependent on opiates. Although I don't know that we can keep up with that number. And we have a questionnaire here at the Syringe Exchange that's talked to people about their use, the primary drugs of choice, all those kinds of things. One of our questions is, have you considered, would you like to be able to have help with treatment to be able to quit? And I can't remember now exactly, but it's like 80% say yes, they would like that. And many of them have been through treatment. Some of them have been to a detox before. They have quit for periods of time and then gone back. Of course, that's very normal. The number of treatments to quit is often around 7 times they've gone to treatment or done something. So it's, you got a patient in front of you and they've gone to treatment since they were, first time when they were 17, and they're 30 something and they've gone 4 times. Well, that next one might be the one that works. So don't give up on that one. We really work here to try to decrease the stigma. We're going to treat this like it's a chronic disease. We often use we talk to our patients a lot of times about diabetes. If this was diabetes, this is how we would treat you. We wouldn't kick you off. We wouldn't stop seeing you because your blood sugars are too high. Well, we're not going to do it just because you've had some relapses. I have a poster here in my office that says, this is the only chronic disease that is, if people are penalized or stigmatized for displaying symptoms of their disease. Plain and simple. And we try to meet people where they are. It's particularly helpful for me because right behind me here is the Syringe Exchange, and that makes it very easy. The staff who work the Syringe Exchange make sure that everybody who comes in understands that we have people here who can help them. And sometimes they get snagged at just that right moment, and they come in and see us and want to get started, and then we don't see them again for several months. But that's fine. We always welcome them back, and we tell them we'll always welcome you back. We'll soon be working in the jails, and that's another opportunity for us to get to have these meaningful conversations with people. Next slide. So here at Blue Mountain Heart to Heart, we're a low barrier, office-based opioid treatment, or LOBOT. This model of care understands that there are many factors that drive people from opioid use to dependence, and those include genetics. It could be that long line of people who had addictive tendencies, personality type, trauma. Of course, we know that adverse childhood events and sexual abuse trauma, all of those kinds of things make you much more susceptible to addiction to many different substances, opiates being one of them. Okay, so how do we differentiate the opiate use disorder in patients like with chronic pain? That's a big deal, and you know, this conversation needs to be, first of all, in the primary care setting, you really need to take a look at this. I cannot tell you how many people have sat across from me telling me that they have lost control of their ability to keep the opiates from taking over their lives, and they are continuing to get prescriptions. And I ask them, when was the last time that you had a urine drug screen? And they will tell me never. And that doesn't do anybody any good. You really need to get a snapshot of what's going on, because if you're seeing that there's opiates that you don't expect, and particularly fentanyl, I'll stress that, and there's also meth and those kinds of things. This is a life that's in chaos. And I would say if there's anything that alerts you to suspecting that somebody has opiate use disorder, it would be their chaos in their lives. They've lost their job. They're separated from their family. They're not looking like they came prepared, or they missed a lot of appointments. That's the chaos in their life that results from opiate use disorder. The motivational interviewing, I'm sure most of you are aware of. You talk to the patients about their perceptions of their problem. And I don't know that you'll get people to admit that they divert their drugs so that they can buy another drug, or that they have stolen drugs from their mother, or that they're using heroin when they've used all their hydrocodone. But I think if you set the groundwork for it, just to know that you have some concerns, and I would say that that's probably that, you know, that's the I'm concerned conversation that you can have that's open-ended. You know, I'm concerned that you've got this prescription of hydrocodone for the last 5 or 6 years, but you don't seem to be doing any better. In fact, I think it looks like things are not going very well for you. Or I'm concerned that when we just did the urine drug screen on you, that there were no opiates in your system, but I do see that there is some meth and some Xanax and, you know, those kinds of things. That concerns me. You want to talk about that. And some people will hesitantly admit that they might, in fact, have used more of their hydrocodone than was prescribed, because they simply don't have enough. The 4-a-day is not working for them anymore, and you know, that's a very common thing, but it's also very concerning. Not only do we need anybody prescribing opiates in the state of Washington really should be getting urine drug screens and checking the prescription monitoring program at every visit. That's kind of the minimum there. And if there are things that show up there, that needs to be addressed. I would say, I can't stress enough that most of our urine drug screen panels, the cups that we get, does not include fentanyl, and fentanyl is on the increase. And those will be the people that you would least expect. There are people, women who are middle-aged who work in offices. There are guys who just have a regular, they have their own businesses. They're doing fine, electricians and plumbers and that kind of thing. And you'll only get that if you actually buy the separate strips for fentanyl or get a cup that has it. They're actually tend to be more highly functional. Next slide, please. So there are several screening tools, and many of which I don't care for. Because of the use of illegal and abuse and that kind of thing. But the ORT, the opioid risk tool, has still some good use to it, because it talks about family history of abuse, substance abuse, personal history of substance abuse, age, history of pre-adolescent sexual abuse, and psychological problems. Of course, they're using the words abuse and disease when psychological disease, and those are all kind of stigmatizing things. And so I'm waiting for a better one to come out, honestly. Like I say, the DSM-5 criteria is good, but you kind of have to establish with patients that they are that they're using their prescriptions, or they're using drugs inappropriately. So certainly the history, lifetime history of use. There's a very good one that is like the second question in the NIDA modified assist, which talks about your lifetime. In your lifetime, did you ever use cannabis, cocaine, other stimulants, inhalants, that kind of thing? And I think most people will be honest with you about, well, I did that in my 20s or something. But it kind of would open the gateway. That is tool that is probably more appropriately used in a different setting, because it is very lengthy, and you're not going to get that in your whatever 20 minutes or so that you allocated with your patient. But the past history of any addictive substance is certainly can be problematic. Family history for substance use disorder, history of problems with the criminal justice system, and history of severe depression, anxiety, or PTSD. I would have to say that in the women that I see, PTSD and from prior sexual and physical abuse is very common. So a daily dose of opioids, 50 milligram a day morphine equivalent up to 100 and over 100 is always concerning, and the length of time that they've been given that is also concerning. We use the COWS score here for evaluation of their symptoms of withdrawal. And so if someone comes in and they didn't use, so that they didn't have, before they come to see the doctor, although that's not my experience now, if they come in and you suspect that they are in withdrawal, the resting pulse rate, the pupils, the nausea, joint pain, that kind of stuff. But we do that at every first visit, and we also do the DSM-5, which has 11 questions, and the answer to that in my practice is generally 10 out of 11 or 11 out of 11 positive. But these are people who chose to come see me for their addiction, and they're very honest about it in this setting. So next slide. So the goals of any opiate use disorder treatment would be to provide tools to help the patient manage their disorder, which, I feel very strongly the medications that we give patients, the Suboxone can be a real lifesaver. I know before Suboxone became big, Methadone was really what we had, and Methadone, I still sometimes talk to some of my patients that maybe Methadone may be the most appropriate for them, although we don't have any in Walla Walla, so that can be a bit problematic, and it's a commitment as far as going in every day or several times a week for the first several weeks. But I think part of the services that we provide with wraparound care is, you know, helping to get people into psychiatric treatment, counseling, help them get plugged in so that they can get some housing. Homelessness is not uncommon in our population. I'm sure I'm forgetting something that's critical, but we we have a real team approach to treating patients. And I try to stress on them that it's a difficult transition from days of constant use to sobriety, because there is just that retraining your brain. How do you cope? And oftentimes when people relapse, it's because they had something very stressful happen in their life. And they had one coping mechanism for a very long period of time, so they need to learn new ones. It is individualized for each patient. So they don't all have the same needs. Here again, going back to the fentanyl, a lot of the patients who use fentanyl have really kind of normal lives. And then I have patients who have multiple drugs of choice, and it has left them homeless and with very few coping skills. So it just depends. Okay, and next slide. Okay, next slide. Is there another one for me? If there is not, oh, is this me too?
I'm not sure where you guys want. I think Everett would know.
Okay.
Yeah. Go back, Diane. Back. No, one more forward. There you go. One more. There. No.
I would just like to, while you guys are figuring that out, I'd just like to make one more dire attempt that if you feel like something's not quite right, just use your best, most sympathetic tone and tell them I'm concerned about you. I worry that this has gotten out of hand. And if you are treating somebody for pain with opiates and you sense that that's not going well for them, that they're probably misusing, Suboxone is an excellent drug for pain and as well as for addiction. It is Schedule 3, so you can call it in. You don't have to print a hard copy. It shows up on the PMP. So you can track it that way. Patients can take it once a day, which is like using the disease model rather than the opiate use kind of model. And it really gets people, Suboxone sticks to those opiate receptor sites and stays on. That's kind of like how Methadone worked. It stuck on the opiate receptor site so that nothing else can get in there, and it stays all day, and so they're not experiencing the roller coaster that they do with opiate use.
Diane, there are some slides on the medication for OUD. So
okay.
Keep going.
Okay, here.
And I actually...
There you go. There you go, Nadine. That's your slide.
You go. Okay, and I think they actually punted this over to Everett, but I'm happy to address this. You know, I like to tell my patients, this is like, if you think of the opiate receptor sites like a cup, and the opiate's going into it as a ball. Well, fentanyl jumps in and jumps back out. Oxycodone kind of goes in, doesn't stay very long, goes away. Methadone gets in there and stays for a good long time. Buprenorphine is about a 24-hour drug. So you get a good dose. They can take it all in the morning. And that stays pretty good. Not quite as long as methadone, but then it also doesn't have the same, electrophysiology of the cardio. It's not going to prolong the QR wave. Let's put it that way that methadone does. Vivitrol can be very effective if given, the injection once a month. We don't do much of that here. I don't have much takers because a lot of my patients have had Narcan administered to them and they did not like it. So they're not as likely to do that. Don't forget buprenorphine, none of it gets absorbed in the gut. So it's a sublingual film. You guys know that there are the patches that we use for pain, and there are also the injections. Subcutaneous injections of buprenorphine, but also none of it is through the gut. Let's see what the next one has. I think this is where Everett is taking over.
Hey, Nadine, this is Becky.
Yeah.
Can you talk a little bit more about when is a Vivitrol dose appropriate? Are there some situations where primary care clinics should be thinking about suggesting Vivitrol, and not just for opioid disorder, but also for other?
For alcohol, right.
Yeah.
So you really, I think that is one of those things that would take some, I know that they use it at some of the rehab centers when people come in and they are both opiates and alcohol. And so they're like, okay, we're going to send you out in the community. We'll give that to you. And I know, I guess first of all, they'd have to be tried on the oral form before they went, make sure that it wasn't going to be a problem for them, but understand that people really have to have a commitment. And there is always the problem of people using it day 29 or 30, then they don't show up. So that's kind of part of the problem for that. They have to be kind of committed to getting the injections. Like I say, I haven't talked anybody into it yet.
Okay, well, we like to use Vivitrol when folks are coming out of jail because they have to not have had an opioid for 7 days.
Right.
And it's not very often folks are off opioids for that length of time with but they do come to jail, obviously, with hopefully not having opioids in the system. And so we like to encourage Vivitrol after jail, which allows us some time to start thinking about another plan or working with them for, repeat injections of the Vivitrol. So I just want clinics to be thinking about that as well.
Yeah. Well, and certainly if you get a patient who has come out of treatment and who has had it within the last, 30 days or less, that could be, it could be something, but I would be careful to get a clean UA if it's been over 30 days. But if somebody, I think it has a potential to be very good. Let me put it that way. Of course, my patient would have to be off of Suboxone. So yes, jail or treatment would be a good place to start that.
Great.
Does anybody have any questions for her before Everett takes the next step?
I do. This is Becky again. I was wondering, Nadine, having worked in pain management, what are you looking at on your patients that are on chronic opioids for pain management? What do you want to see on effective pain management in terms of their function, their lives? what does it look like when you're doing a fine job with pain management, the lowest dose, and the patients are doing well? What does that look like?
Well, of course, it depends on the underlying disease state. You know, if you're talking about somebody with really bad MS and they're 40 and they are not being able to take care of their family very well because of the condition, or the severe rheumatoid arthritis, you have kind of a different level. But, you know, if they're able to maintain their jobs, if they come in and make their appointments, they don't call in for lost or stolen medications, they don't have car accidents and, you know, all of that kind of chaos, then they're probably doing okay. But, you know, we have created physical dependence for them. So you can't just, you know, you can't just take it away from them and they're going to go to something else. They're going to get it some way or another. But yeah, their physical functioning is certainly a big part of it.
Thank you. Is Everett on for this next piece?
Sure, I'm happy to take the decision-making process. Good morning, everybody. Thanks for coming in. It's nice to see everybody's names. I can't see your faces. So one of the things that, when we look at all or across treatment programs, no matter the model or intervention design, we need to see, you know, recovery is sort of hinging on two major steps for the patient to take. One is behavioral change and one is environmental change. And so this low barrier OBOT program is really kind of designed to try and help them make those behavioral changes through medication support, and then some counseling and other kinds of you know, new ways of, as Nadine referred to earlier, new kinds of coping mechanisms that are not as self-destructive for the individual, and also help them with environmental changes. So if housing is a barrier, and that presents as a very big barrier for many of our clients, you know, we have housing assistance as part of the Opioid Resource Network to try and place people or move them out of abusive situations or DV situations that they might be that might have at home, and so in addressing both of those major areas where we're going to need to see change in order for them to have long-term recovery, you know, we've modeled the program around making those changes, kind of facilitating changes for them. So in that same way, this decision-making process is an attempt to begin to model for individuals how to even communicate with a provider, to begin to understand the options for their care and treatment, and then help them kind of engage directly as drivers of their own care. Because as Nadine mentioned in the beginning, the stigma around drug use, even around medications, drives people away from locating themselves as in control of their situation, and they really kind of come into our clinics and our syringe program sites, you know, sort of declaring that things are out of their control, things just happen to them. Some trauma from the past has, you know, kind of taken away their own autonomy. And so this decision-making process is like one of the first steps to kind of help them be able to assess where they're at and what the options are for them. So step one is really, you know, having that motivational interviewing, trauma-informed care type conversation with them where we talk about what the options are for them, and we'll go through different medication strategies. And I do want to just note that on October 13th, which I know has passed, there was a public comment period for a new methadone clinic coming to Richland on Spalding Avenue. So there will be a methadone clinic in the Tri-Cities in the near term. I think this firm is out of Bend, Oregon. So it will be something that I think will be publicized more to area providers, and as we all get more information about eligibility and how that clinic is going to work, then that's something we can present to people as well. So step 2 is really helping them compare their options, and it facilitates a conversation with the patient about where they're at, what their capabilities and limitations are, and helping them kind of differentiate between treatment options and also some of those wraparound supports. So for some of our patients, they really want to get into addiction-focused acupuncture, chiropractic, physical therapy. If they do have chronic pain for something, if one of those other kinds of provider relationships can help support the pain that they are complaining about. So next slide. Okay, so in this step 2, this is really adapted from the Depression Decision Making Guide, which has shown there's evidence that this is really helpful for people with OUD, not just because they so often have comorbidity with mood disorders, but also because it's a decision-making process that allows for people with low energy or low kind of fidelity around these conversations to be able to participate in their own care. So it does involve some, wait and see on the part of the provider and the patient together, talking about what kinds of social supports they have in their lives, and then helping identify for them how they could start improving their social support network. If, as often we see, and I think Nadine alluded to this earlier, this is also gendered. We often see people who, the folks that are in their lives at this point in their substance use behavior, they're not people that have their best interest at heart. They're also, there are other people also using drugs, or they might be dealing drugs. They're alienated from their families, so which would be otherwise a big social support for them. So we kind of want to go through with them, who's in your corner with you, and then start to try and identify some professional counseling so that they can be working with someone on new coping skills. We hear a lot people who've been on Suboxone a couple of weeks to a couple of months that, they feel like they have their head on straight again, but now they realize, all the things they've done wrong while they were using drugs, and all the people that they've hurt. They have a lot of shame and guilt around that, and now they need some new way of coping with the stress of those realizations that is not using drugs. So counseling can really come in here, outpatient, or even if some of our people will get onto Suboxone and then say, I'd really like to be in inpatient treatment now that I realize what's been going on with me. So, we need to have that conversation with them as well. And then the medications, as Nadine outlined earlier. Next slide. So this is the part of the decision-making process where the patient begins to start taking control over determining what's happening for them. So we'll start to ask them about, how it's going for them. This is, what do they, if they've ever used Suboxone before, because many of our patients have, we talk to a lot of people who have used it on the street, or, bought it kind of on the gray market, or, borrowed or took some from a friend. So we can ask them, what was that experience like, and what would you like to see happen better? With a professional guiding your, treatment. Then step 4 is really like help them work through what are the advantages and disadvantages of each option, leading to the actual decision, which is one that they make. So this is really another way of looking at this is an informed consent model, where the provider kind of lays out what the possibilities are for folks, and then helps the patient really direct where they want to go. And there's lots of time after this decision is even made to be able to say, does this continue to work for you? As Nadine said, we haven't gotten anybody really to go from Suboxone film to, a 6-month implant or anything like that. And we've had a couple of people think about moving over to the withdrawal, but we haven't actually seen that happen. Next slide. I'm ready for the next. Oh, I think go back one. Yeah, okay. So the point really here is to try and, we're always looking at 2 levels, and this is kind of a nice nod to public health. We care about improving individual health, and we care about improving community health. So in trying to, alongside helping individuals who are dealing with opioid use disorder, we're also trying to help educate the public in general about what drug use is really about. It's really a chronic condition. It deserves a continuing care model, on behalf, or provided by compassionately oriented providers in social services and in clinical services. We do know that the overdose death rate is 50% lower when we are trying to address recovery with medications compared to abstinence-only programs or no attempt at recovery at all. So, it's really a good reason to try and educate providers about OBOT or MAT or whatever we want to call buprenorphine and methadone and naltrexone. So there's a really good point to building knowledge because that does help drive people into attempting recovery. We've said before, we need to meet people where they are. What we're trying to do is get the highest risk people at the right time and the right place. And those right times and places really do seem to be syringe service programs, jails, emergency departments, exactly where you would think you would find people using drugs, overdosing, seeing their lives out of control, and that's when they become to be more contemplative about recovery. We know that the treatment decision-making process helps people begin to take control. We know even going to a syringe service program increases the likelihood 5 times for that person that they will attempt to get into recovery. So, we really want them to be making connections to and increasing access into treatment, because then it's just more likely that we can put the people who need care into the care situation. And so treatment really, at least on the opioid side, does seem to have some good tools in the toolkit regarding these 3 major groups of medications, and then as many support services as we can throw at people, and an intense or comprehensive case management support service for people does seem to drive long-term recovery. Okay, next slide. So one of the things that's happening now between Consistent Care and Blue Mountain Heart to Heart is that we are increasing the collaborations that we have with external partners. At Blue Mountain Heart to Heart, we now also have, along with the Walla Walla satellite of comprehensive mental health, a new law enforcement assisted diversion program, the first one east of the Cascades. We're in planning with that program right now. Blue Mountain Heart to Heart is going to be taking over the behavioral health and medical contract for Walla Walla County Jail. And so we're going to be revisiting how Suboxone is being delivered in that setting. So these partnerships, really help with, increased referrals, increased encounters with high-risk folks or high utilizers. The wraparound care that responds to barriers. Obviously, housing is a really big problem right now. There's no movement in housing in Washington State with the holds on evictions. And while that's a good thing for people who are at risk of being evicted, it also means that at the lower end or the more affordable end of the housing spectrum, we can't really get anybody into properties right now. So folks that are houseless are, you know, continuing to have to stay in shelters or, you know, couch surf or just be on the street. I think another new horizon are more innovative services like recovery cafes. I can't think of one in Eastern Washington, although there might be one in Spokane, but they're mostly on the west side, but they're really helpful in terms of, you know, letting people in recovery kind of be self-directed. As I said, destigmatizing MAT is really helpful. And then we're seeing now more overdose deaths in Washington State among psychostimulant users than opioid users. So the big push on naloxone across the state has really helped, you know, stem overdose death for opioid overdose, but we don't have any medication to help folks recover from stimulant overdose. And it's also much harder to identify a stimulant overdose because it could be something, you know, cardiac related or stroke related, and it's hard to know that what drove those events was a stimulant until toxicology comes back, which is always rather late in the process. So, you know, there's some work on trying to figure out how to help stimulant users. And then the other is supporting pregnant and parenting clients, because they often don't want to be honest or tell us what's really going on with them because they're too afraid of having their guardianship revoked. So that's something that I think is a legal and advocacy issue for the future. So I think that's it from my side.
Everett, this is Becky. I just have a question. I'm wondering if you could shed a little more light on Suboxone prescribing and the need to have Suboxone prescribers within primary care clinics, and what it takes to be a prescriber of Suboxone. Okay.
Well, I think the good news here, so it is, you know, there are some challenges because it is a DEA waivered substance, right? Classified substance. So you have to go through, if you're a DO or an MD, you have to go through what they call the half and half. So 4-hour in-person, although I don't know if it's all online now, training, and then a follow-up of another 4-hour, you know, webinar type training. If you are ARNP or a PA or a couple of other mid-level certification provider, then it's a 4-hour in-person, quote unquote, and then a 16-hour online training after that. But at that point, you can prescribe to 30 people. I think it's per month, and the dean will correct me if I'm wrong. So to get that, it's really not very difficult to get that X waiver for buprenorphine. And I do really think that every primary care practice should have a buprenorphine prescriber. And then if you don't want to carry those people forever, you want to be able to refer them, that's fine. But if you being able to just even do an induction is really helpful. Once you hit the 30, then you can apply through DEA for your 100-person waiver. And then the cap after that is 275, but you need to be at the 100 level for a year before you can even ask for the 275. And there are a couple extra requirements to get to 275, but I don't think any primary care practice would really need to go over 100. You know, if every primary care has one, then, you know, they can handle sort of the, you know, those patients who need that assistance. And then if those patients need more assistance or they need more comprehensive care around their buprenorphine prescription, then they can get referred into another program that's going to be able to help them with more comprehensive services for that. Does that answer your question?
Everett, this is Ann. So where can a primary physician get trained in that?
Well, so I love this guy's name, Daniel Otter, O-T-T-E-R. He sounds like a character on like a kid's show. He is the physician at DOH who sets those trainings up. So DOH has a commitment to running these trainings around the state to help encourage mid-level and physician providers to getting trained. And I am happy to dig up his email and put it into the chat so that folks can contact him. And he usually has a schedule going anyway, but if people from a given area all start chiming in and saying, you know, we want more in our region, he'll go ahead and set something up just for those folks. And again, I'm sure it's all online right now, so it doesn't really even matter geographically where people are, but you know, non-pandemic times, that's how it goes for him. So let me, okay, I got his address right here. But he's the person who sets those up, and they're typically, you know, the no cost to take that training. So that's his email.
Thank you. All right, are we ready to move on? William, do you want me to hand you the reins to your computer now, or what?
I think you can keep it, but I might grab the monitor from time to time.
Okay.
We'll see how it goes. Bear with us, everybody. Okay. Yeah, I'm William Waters. I'm a director at Comprehensive Healthcare and a psychologist. And the first thing I want to do is just to ask everyone just to take a breath for a minute and just kind of think about what you might be worried about, having learned what you've learned so far, what any fears that you may have. Moment, take a breath. What I fear is that I'm in an echo chamber a little bit. I know some of you, and some of us are proponents of this. What I'm hoping is that there's some kind of echo that gets out of this room. And I hope that you kind of think about what it is that you actually want to do with the information that you've gotten today, to take actually something to do it. Yes, I'm a psychologist. You should have known that there'd be some kind of behavioral activation included in this presentation from me. So yeah, please think about something that you're going to do. I fear that the information stops here, that we actually need to do something and get motivated. For you providers here online listening in, you're not alone in this. And that's, you know, there are resources and there are groups of people that have wrap around what you're providing and take the reins for you in many different ways. So I'm really appreciative to Nadine and Everett. They've covered some of the things that I wanted to share, which is fantastic, which means I can talk about some other things a little bit more, particularly with, and we can go to the first slide, you know, how to, yep. Oh, I'm not sure what you can see right now. What are we looking at right now? Okay.
Oh,
Hopefully
perfect.
you can see my little net picture. Hopefully, so what you should be looking at right now is a diagram, if you will, of some of the destabilizing kind of factors that do really affect behavior towards addiction, and being able to maintain a substance-free lifestyle, or be able to maintain medication management, if you will. So this kind of comes from network theory, something called the graceful degradation theory of networking, suggesting that, you know, as we have a destabilization of certain types of behaviors, ideas about ourselves, communication with other people around us, that each of these factors influence one another. As you are meeting with patients in your primary practices, you will likely begin to see a degradation about how, like, their lack of sleep is really affecting their ability to really get on with friends or get to work on time. You may begin to see that their self-esteem is really affecting their ability to stay on top of jobs that they need to do. It's affecting their anxiety, it's increasing it. All of these things combining to weaken this net of ability to catch any kind of cravings or urges or behaviors that want to get through to using substances again. So what we're talking about here is, like, behavioral changes that need to occur. And this is not something that you're going to do in the doctor's clinic. This is where you need to reach out to some help. And that's where behavioral health clinics like ourselves come in, and others. And what we're going to do is we're actually going to work on each of these factors together with case management, individual therapy, employment services, and connections there. The idea that is, as instead of a graceful degradation where one thing weakens another, our hope is to be able to strengthen that, where one thing strengthens another. That we begin to build again this network of personal resilience to those kind of cravings and urgings that are likely to come through. So one of okay, I don't have the slides, but that's.
I'll go back.
Yeah, go ahead. One of the instruments that we use is the BAM. It's the Brief Addiction Monitor, and we've talked about a few different screening tools today. In one of our routine visits from Joint Commission, we learned about some of the advantages that are in, I guess, some of the science that's out there in regards to outcome-based measures in treatment. And this is one that that we use to be able to measure changes in addiction. So this was developed in conjunction with the VA in Philadelphia and the University of Pennsylvania School of Medicine. And while it's used in behavioral outpatient clinics, it's also used in primary medical clinics as well, with your doctors, with your ARNPs, and so on. It's very face valid in that the questions really do just look at, hey, are you using? You should be able to see this screen, I hope. And it covers all of the elements in this network that we were talking about before. So how's your physical health in the last 30 days? Sleep, depression, the use of drugs. What are your cravings like? What is your confidence to be able to abstain? Are you participating in any type of AA or self-help groups? How many amount of days in which you're in situations that you put yourself at risk to use a substance? The amount of days that you were working or volunteering. If you had sufficient income, did you have any social stresses or arguments? The amount of contacts that you had with recovery supportive people, and basically like a satisfaction with your recovery and goal progress. So what these all add up to is to suggest a type of risk score, a use score, and a protective score that you can monitor month to month. This is not an instrument that needs only be used in an outpatient setting. They've found that use from these types of tools in primary care clinics is actually very supportive and increases the outpatient success and engagement of clients. And that's the kind of integrated healthcare that we're looking for. You are already measuring hypertension, asthma, COPD, diabetes. These are routinely tracked. When you're working with a client that has told you that they are using opiates or are on a medicated assisted treatment, this is a measure that you can use in conjunction and maintain in your records. What you are going to be doing is helping them to have success, to engage with outpatient clinics. So let's go back to.
Do you need the screen? My screen now?
Yeah, if you can pull back.
Okay. All right. Just a heads up, we have about 25 minutes, so I just wanted to give you that heads up.
Yes, so we want to get to the panel discussion here in a moment. So let's skip to the next slide. So what are some of the conversations that you will want to have with your patients that are in front of you? How are you going to use these scores, for instance, when you find out there's a high risk, there's a lot of risk taking? or that they're really not doing many protective things. They're not really engaging in mending those relationships that are continuing to cause them stress. This is where we use those kind of MI skills, motivational interviewing skills. We begin to explore the ambivalence, like what is going on here? Are you satisfied with what's going on? So this DARN-CAT acronym is a great one, I think. You look at the desire, the ability, and the reasons and needs for change. This is the things that are going to help you prepare the conversation to be able to mobilize them into action. Find out what it is that where their values lined up. Is this really what you want to be doing? Are there other ways in which we can think about this? Are there people that you can reach out to? And then try and work towards some kind of committed language or action steps to be able to take towards referring. Like maybe experiment. Why don't we experiment with reaching out to a behavioral health provider? Why don't we experiment with therapy for a while? What is the worst that could happen? Oftentimes, as Nadine was talking about, there's a lot of shame and there's a lot of actual perfectionism with those that have been using substances for a long time. One of the maladaptive schemas there is that clients often feel like this tyranny of shoulds. I should have been able to do this by now. I should have my life together by now. Why don't I have a job? I should be doing this. This is a great place to be able to work on that ambivalence and say, hey, why don't we experiment with making a little bit of change? Why don't we experiment with reaching out? So let's go to the next slide and experiment with that. So how do you refer? Okay, so Tri-Cities actually has a lot of outpatient behavioral health programs that do have case management. And it is as simple as making a phone call, but please call around, because what we have found is the sooner they get in, the more likely they are for having success. You know, don't just provide the one referral. You need to have someone following up and saying and calling with them, like, did you get in today? Did you get in this week? If they're waiting a month for an intake assessment, you're losing the battle. So part of this network and working with the Opioid Resource Network is to be able to provide a connection. You can call them and they will help hunt down that service for them and get them in ASAP, and follow up with them. Go back and do that BAM with them if you want. That BAM, brief addiction monitor that I showed you, it's free. If they're coming back and still scoring high or no changes are happening, look at it as an objective measure. Okay, hey, look at this. This is still a concern. You were concerned about this yourself. What are we doing about it? So the objective here is to work on that ambivalence, increase the integration of healthy parts of self, things that they can do, and get them referred. Yeah, I think I'll leave it there.
Great. Thanks, William. This is Becky. Diane, I think I'll take it from here. So the Opioid Resource Network is a program completely funded through Greater Columbia Accountable Community of Health. It's across Benton, Franklin, and Walla Walla counties, but we have some new opioid resource networks in some of the other counties. Our ORN is a partnership between Blue Mountain Heart to Heart, which is Everett and his team, as well as our team here in Benton, in the Tri-Cities, and in Walla Walla. Go ahead and next slide. So I'm the Chief Operations Officer. Darren is our Medical Director. He's an ER physician out of Spokane. And then my team is also on this call, Trissa, Lindsay, and Raina. Okay, go ahead and move forward. Through the ORN, we developed this as we were brainstorming under our first initial meetings under the GCACH, and what we wanted to do was create a ORN which would be a resource for you. We knew that for many of the clinics out in our community, that managing OUD is tricky and a bit scary, and they weren't quite sure exactly how and where to send patients. So we wanted to make it super easy for you, so that when you do identify a patient in your clinic that could possibly have opioid use disorder, and you can take away a lot of the information that we gave you today, you would have a place to call and you could pass the baton off to. We hope that before you pass that baton off to you, that you've done some of this scripting and conversation and shared decision making that we've shared with you today, so that when a patient is referred to us, we have a framework and your support in beginning to work with those clients. But basically, the ORN is a one-stop shop. It's run by our nurses and community health workers. Everett has staff as well. But it's basically super easy for you to send us a referral. We have our website here at the bottom of this slide, consistentcare.org, and you can send us any patients that need help navigating into treatment for OUD, and just give us the name and number and we'll reach out directly to those folks. So that's one source of referrals, is directly from the clinics. Patients can also refer themselves in, and I've done a number of radio spots, newspaper spots, so that they know that this service is out there and available. Some of the other things that we're doing in our reaching out into the community to try to find this population is we are now getting reports from all 3 cities in the Tri-Cities, Kennewick, Pasco, and Richland now. We're getting overdose reports every morning. So anybody that's administered Narcan out in the field or has an opioid overdose, we're actually making cold calls and reaching out to those individuals to talk about readiness for treatment, and if not, access to Narcan and syringe service programs. We have a partnership with New Start, which is a MAC clinic, and we are seeing folks on their second visit and doing a complete intake to see how we can support them in their recovery. We are also doing a lot of internal referrals, so we do ED diversion with the emergency rooms in the Tri-Cities and Walla Walla, and so we are identifying folks through that need the service. And then we are also meeting with Greater Columbia practice transformation navigators and meeting with folks that are trying to transform their healthcare, which is all of you folks, and trying to educate on how to refer folks into the ORN. Okay, next slide. Next slide, Diane.
I have been doing it. Did it not go?
No. Is that the next one?
This one?
Sure. So this is what we do. We can provide the wraparound services. So we are not a MAP provider. Everett is. Everett can prescribe medication. We are not. Our goal is to identify patients, reach out to them, and help navigate them into a MAP provider in our community. But on top of that, our goal is to provide wraparound services so that they can be successful in that. So we have funding for providing bus passes. We also can take them to appointments, to their MAT appointments. We do a pretty extensive intake assessment to identify what all of their challenges are to recovery, and can help with getting food, clothing. We can provide cell phones if folks don't have a way to communicate. We also can help with medical care coordination, so helping them get that primary care, get some dental care resources for women that might be pregnant. Of course, we always encourage engagement in behavioral health services, like William just talked about, as well as SUD counseling and support. And also, if they have legal services or legal challenges that are creating a barrier, we will advocate on their behalf for that issue as well. Okay, next slide. Okay, so this is just a flyer that we have out in the community that basically lets everybody know that we're just waiting for your call, and we will find out what it is you need and provide that service. So we want to leave some time in this presentation to make sure that you are all, we have some discussion time. And then I think we have a couple slides on Blue Mountains ORN. Yeah, there we go. So Everett.
Okay, hi everybody. So we have two sites for our OBOT program, our low barrier bupe clinics, and one of them is on the Southgate area of Kennewick, and the other is actually also on the south side of Walla Walla. That was not planned, but kind of funny. So you've met Nadine, our prescriber in Walla Walla. She's supported by Melissa Cross, our nurse case manager, and then our and Liz Fraser, our MSW. And then in Kennewick, we do have a contract with New Start Clinic, and that's Joe DeBose who's doing our prescribing there. Nathan Van Vickels, our nurse case manager, and then Rebecca Michaels, our care navigator. So, you know, solid teams. Next slide. And as I tried to be parallel with Becky, with community providers or partners. Yeah, there you go. So, you know, we're working with a lot of different people. You'll see there's law enforcement that we work with, and medical providers, folks at hospitals, other MAT providers, primary care. So we're trying to find people where they pop up, and obviously a lot of our folks that come in directly through our own syringe service programs. So next slide. We know that co-locating prescribers in these settings, as I said earlier, finding the highest risk people at the right time and place, going to where they are. We're with this new LEAD program, diversion program, we're going to have, you know, basically people in the field. So we'll be at bus transfer stations and other kinds of places where, you know, shelters, homeless camps, where we think people might be, you know, staying or hanging out. And we'll try to make encounters with them there. The goal, again, is to start people as soon as we can on Suboxone when indicated, with their COWS score, right? And then try to keep them on with minimal constraints for up to 180 days. So that's why it's a transition program, and then get them into primary care. So this dovetails nicely with the Opioid Resource Network. So we kind of bring both sets of programs to bear for folks. And then, you know, you should read the bullet point later about you know, our kind of commitment to people who are in distress because of OUD, that they deserve to understand their medical condition, know the full array of options, know what the advantages and disadvantages are, and then be able to take increasing amounts of control over choosing their own health care. So thank you.
And then I wanted to add that there are other opioid resource networks throughout our GCACH, and I just was going to pull that up as well. Okay. That way we have them. So we have an ORN in Whitman, and it is with Palouse River Counseling, and Kim Thompson is on the line now. She's on the phone today. And there's an ORN in Stoughton, Columbia, and Garfield, which actually is run by Blue Mountain Heart to Heart and Tri-State Memorial. And then in Kittitas, there is an ORN, and Mitchell Rhodes is the person in charge of that one. In Yakima, they actually have the Opiate State Hub and Spoke program, and that is Comprehensive is in charge of that. So now I guess we could go back to the discussion.
Yeah, I think we should just take questions. I think I'm done.
Okay. So let's, Chelsea, can you unmute everybody and so people can ask questions? Well, I think I
muted.
And I just want to remind you that we have about 10 minutes
Muted.
We have a hard stop at 1, just because we have another meeting that is scheduled through our go-to meeting. So
Here, I just
perfect.
say this. Sorry, I'm hitting unmute. There we go.
Okay, perfect. So we'll open it up. Does anybody have any questions for Everett or Becky or anyone else on the panel? Okay. Well,
Diane, this is Becky. I just want to let everybody know that we have Opioid Resource Network work group meetings every other month, and we will be having one in November. And we would love to have folks from this call attend those work group meetings. And if you're interested in that, if Diane, if you could send out our contact information, folks can reach out to me and invite to folks that might want to join us in this conversation.
Diane, this is Wes. Can you hear me?
Unmuted.
I think so.
Diane,
We can hear you, Wes.
can you hear me?
Yes, we can hear you, Wes.
Okay, great. Thank you. Thank you for all these great. I'm hearing some background noise. If someone has some background noise, if you could mute your phone, that'd be great. This is really a great series of presentations. William, Everett, Nadine, thank you so much. I'm just wondering, from the standpoint of a provider office, is there a package or a toolkit that sort of wraps these in a real practical sort of a practical constructive tool that providers can just run with some instructions, some sample phrasing and wording to use with patients, simple instructions. Maybe I'm overreaching here, but is there anything practical that can be sent to provider offices relating to everything that was talked about today?
Well, I love that idea, Wes. I will, if it's not there, I'm working on it.
Yeah.
Thank you, William.
Yeah.
Screening tools. Are you talking about like screening tools, maybe sample scripting, resources, that sort of thing?
Exactly. So, I don't take for granted the minimal amount of brain time or thought that providers have to devote to anything because of their very, very busy schedules. And so something that's sort of wrapped in a real practical, sort of short, succinct, concise way seems like it would be useful.
Well, maybe we can work with the practice transformation navigators to pull something together that can be shared with everyone.
I think that would be great, Becky.
Yeah.
Okay. Let's get something together. I don't know who'd do that, Diane or Chelsea.
Yeah, I can help with that, so we can make it work.
Okay, great. I would like to hear, I know we just have a few minutes, but are there specific challenges that clinics have regarding this? What is the toughest barrier to overcome in addressing OUD with patients?
Hi, this is Teresa Adkisson from Triumph in Yakima. And I think our biggest barrier right now is withdrawal management services. I think with the introduction of so many different medication-assisted treatment options, it's really hard to get MCOs to be willing to pay for withdrawal management. And for those patients who don't want to be on medication-assisted treatment, their options are really, really limited. And what we're seeing is a lot of withdrawal management programs closing their doors. And so getting patients into treatment, a level 3-5 or a level 3-3 in our case, who are stable enough to be in those environments, is becoming increasingly difficult.
I'd like to address that. This is Nadine. And the medication regimen that is recommended, and I do all the time to get people to they need to be off opiates for anywhere from 15 to 24 hours before they can start it, is a combination of oral clonidine, ondansetron, and hydroxyzine. The clonidine is a 0.2 milligrams, and I give that to them to take and tell them to take it, all three of them together, every 6 to 8 hours, and then as needed after that starts to wane. And the clonidine, of course, is just a miracle drug to help with those the autonomic nervous system activation that happens with withdrawal. And lots of people have experienced the nausea, so the ondansetron is good. And the hydroxyzine just kind of works well to enhance the clonidine and reduce the anxiety just a bit.
Thanks, Nadine. We have seen a lot of doctors prescribe something along those lines in that combination. Our issue is that we can't have the patients in treatment when they're unstable in dimension 1 and 2, according to ASAM. So having a patient that comes to us who is stable like that after a couple of days on that medication without any kind of withdrawal management intervention, it's just, it's a bit of a challenge. It's an obstacle for them to get to treatment.
Yeah. So hopefully the new recovery center that we're all hoping happens will help with that issue. Anybody in primary care? How are you feeling? And I know we only have 3 minutes, but anybody in primary care have a barrier they want to bring up? Okay, great.
All right. Well, thank you guys so much for providing this information to you and to everybody that came online today. We really appreciate it. This information will be on the CSI portal as well as our website. And then I will work with Becky and Everett to see if we could put some kind of, and William and Nadine, to put some kind of toolkit together that we could get out to providers. Thank you so much for being part of this today.
Thank you.
Thanks, Diane.
Thank you, Diane.